Welcome to Crisis Intervention in Preventing Suicide, brought to you by allceus.com. When talking about crisis intervention and suicide, we have to understand a certain set of definitions and general principles. Suicide, suicide attempt, aborted suicide attempt, suicidal ideation, and suicidal intent all involve the idea that the person wanted to die. They are trying to end their life. As opposed to suicidal intent or suicide, deliberate self-harm is willful self-inflicting of painful, destructive, or injurious acts without the intent to die. So, for example, someone who engages in cutting behavior, yes, deliberate self-harm, no doubt, but they don't intend to die. Someone who shoots themselves probably intends to die. But you can look at, where did they shoot themselves? Did they shoot themselves in the leg? Probably didn't intend to die. Client-centered care means clients are viewed as whole people and includes advocacy, empowerment, respecting clients' autonomy, voice, and self-determination, and encouraging their participation in decision-making. A cognitive key is the perception the individual has about the events that led to the distress. So there is an objective situation that led to the current state of things. But the person's perception, the cognitive key, plays a much bigger role in how they feel about what happened and obviously how we got to where we are. Danger and opportunity is a dichotomy associated with a crisis. Empowerment is an interpersonal process which encourages clients to take control and builds on their strengths. All clients have strengths, or they wouldn't exist. It's up to us to help them identify their strengths, because when clients are in crisis, a lot of times they forget about their strengths. They forget how they've solved problems before. They feel helpless. They feel hopeless. And it's our job to help them realize that you've gotten through things before. Let's see how you did it and see if we can build upon those strengths. Empathy is your ability to perceive and understand another person's emotions. It's not sympathy. You don't feel bad for them. You get down there with them and you try to help them get through the process. Their level of functioning is the way they behave in all aspects of life. You can have an emotional level of functioning, and you can also have a level of functioning at work, in relationships, etc. And it may not be the same across all domains. There are certain basic principles in crisis intervention. First, all clients perceive events uniquely. And all clients deserve to participate in care that's respectful and not judgmental. So even if you don't agree with the way they perceive the event, it's not your job to make a judgment. You need to be respectful and non-judgmental of their perceptions and their feelings and help them get through the situation. Reflection and empathy is most effective with clients at this stage. And ego strength is variable among individuals and is influenced by past experiences and social support. I know some of you out there are cringing because ego strength is really a Freudian sort of concept. But ego strength is their personal fortitude, their ability to deal with what's going on right now. All clients and families are actively involved in collaboration and decision-making. Now, the client, yes, not always the family. It's up to the client who's involved in the decision-making. But if the client wants the family involved, then you want to involve them. Stress is a normal part of existence and can foster self-development and growth. Some people just need a little nudge to help take that step towards growth. And all clients are capable of assuming personal responsibility. All clients grow and change in environments of acceptance and trust and empathetic understanding. Don't be judgmental. Accept where they are, accept who they are, provide an environment in which they can trust you, and be empathetic to them. Sustained change occurs when clients feel ready and supported. We see that in our own life. We're not going to change until we're both ready and supported. People have a need for mastery and self-control, and crises can be construed as danger or an opportunity for growth. Crisis intervention is an active process that focuses on the immediate problem. It's not time for us to delve into people's long history of manic depression. It is not time for us to start talking about all the traumas of your childhood. It's time for us to deal with this immediate problem and help you get through today. Crisis intervention is time limited. Advocacy is an essential component. You need to advocate for the client to be heard. By the time they get to the point that they're in crisis, they don't feel like they've been heard. They don't feel like their needs have been met. They don't feel like they can meet their needs. So it's your job to help advocate for them and help them get their needs met and access the resources that they need. The focus is always on increasing the client's level of social, occupational, cognitive, and behavioral functioning. There are three core components of crisis intervention: a precipitating event, the perception of the event, and the client's usual coping methods. When you get in a situation when a client is in crisis, the first thing you want to do is develop rapport and maintain contact. Work with them to identify the problem, assess their risk to life, explore their coping skills, their strengths, and their supports. Negotiate. Notice this means talk with them. Negotiate an action plan. Help them implement the plan and follow up on the plan. Most of crisis intervention, as you'll notice, doesn't focus on talking about the problem. It focuses on talking about the solution, the strengths. Prevention is always the best, though. There are certain levels of prevention. Primary prevention means it doesn't happen at all. You prevent it from happening at all. Secondary prevention means you intervene early. Tertiary intervention means you intervene, it's a little later in the process, but you try to prevent all of the side effects of whatever the problem is from causing more problems. So step one is to develop and maintain rapport. There are 4 necessary components for the development of therapeutic communication competence. You have to have an appropriate knowledge base. That means about individuals, about crisis, about whatever the issue is, and about multicultural sensitivity. You have to have a range of behaviors essential to effective performance. You can't just always have a client come in and sit down and look at you and spill their guts. You have to have a range of things that you can do in order to develop rapport with a client, because not everybody is going to mesh in a certain way, in the same way. You have to have a positive attitude and a valuing of communication, both verbal and nonverbal. And you have to provide an availability of opportunities to communicate. Again, not everybody communicates in the same way. A child communicates much differently than an adult. Adults all communicate differently. So you have to be open to different behaviors and different methods of communication. I've worked with cops for a long time, and they refer to feeling as the F word. You don't want to ask them about how they're feeling. What are their feelings about this? Reactions is a much more acceptable word to them. A lot of cops like to talk about what they did, what happened, but if you listen to how they're communicating and what they're telling you, you can get a sense of what their feelings were, what their reactions were. Don't force somebody to communicate in a way that meets your style, but doesn't meet their style, because it's not going to work. Assessment. When you're conducting a suicide assessment, you want to obtain information about the patient's psychiatric and other medical history and their current mental state. Identify specific factors and features that may generally increase or decrease the risk for suicide and that may serve as modifiable targets. For example, are there children in the home? Do they have a job? Do they have housing? What things may make it worse? What things can we do? What sorts of things might mitigate their intent to commit suicide? Address the patient's immediate safety and determine the most appropriate setting for treatment. Develop a multi-axial differential diagnosis to further guide planning and treatment. And it's important to remember that suicide assessment scales lack the predictive validity necessary for use in routine clinical practice. What does that mean? That means suicide assessment scales have some use, but in clinical practice, you don't want to rely on them to tell you, yes, this person is suicidal, or no, they're not. Important domains of assessment. The patient's current presentation. Is their attitude flat? Are they highly emotional? Are they behaving appropriately? Did they dress? Did they bathe appropriately for the situation? What are their strengths and weaknesses? Emphasis preferably on strengths at this point. What's the history of their mental health issue? What's the history of this crisis? Have they attempted suicide before? And what's their psychosocial situation? Do they live alone? Were there recent psychosocial stressors? What's going on? When conducting the assessment, you want to get information from the patient, of course, but also, if you can get a release, gathering information from family members and friends and others in the patient support network provides a whole lot of additional useful information. Types of information that you might want to get include the patient's current mental state, activities and crises, any behaviors suggesting suicidal ideation, plans, or intentions, such as finalizing plans, saying goodbyes, giving away prized possessions, etc. Stockpiling medication or weapons. A history of suicide attempts or other self-harming behavior, and information about the timing, intent, method, and consequences. The timing. If they're bipolar, did it occur during a manic episode, during a depressive episode, when they were coming out of a depressive episode? Does it occur immediately when the person goes into crisis, or was it after a long period? How are prior situations similar to and different from the current situation? What types of opportunities does the patient have to fortify their social network? If it's necessary to protect the patient's safety, you may need to share this information without the patient's consent. Gather information about the patient's cultural and religious beliefs, particularly as they relate to death and suicide. Assess the nature, frequency, depth, timing, and persistence of suicidal ideation. That's a lot more than most of us look at. What's the nature of their ideation? Do they want to die? Do they have a plan? The frequency, how often does this ideation occur? Depth, how serious is the ideation? Are they making a plan? Do they have the access to the means? Are they making final preparations? What's the timing and what's the persistence? Is suicidal ideation fleeting? They think about it for a day and then they get over it, or have they been contemplating suicide for 6 months? If ideation is present, request more detail about plans. Simply asking about suicidal ideation doesn't mean that you're going to get accurate or complete information. So make sure to ask questions, specific questions. It kind of feels like pulling teeth sometimes, but patients who are thinking about committing suicide are ambivalent. Part of them does want to die, so that part of them is not going to give up everything. In summary, you want to identify specific psychiatric signs and symptoms, assess past suicidal behavior, including the intent of self-injurious acts, review past treatment history and treatment relationships, identify any family histories of suicide, mental illness, and dysfunction, identify current psychosocial situations and the nature of the current crisis, and appreciate the psychological strengths and vulnerabilities of the individual patient. When you inquire about suicidal thoughts, plans, and behaviors, again, ask specific questions. Start out with things about, how do you feel about living? How does life seem to you at this point? Have you ever felt that life was not worth living? Focus on the nature, frequency, extent, and timing of suicidal thoughts, and the interpersonal, situational, and symptomatic context in which they're occurring. Suicidal ideation in and of itself occurs to most people at some point or another. The persistence, the frequency, the depth, and the context varies. Elicit the presence or absence of a suicide plan. If they don't report a plan, ask whether there are certain conditions under which they'd form a plan. Regardless of whether a plan is present, if the patient has acknowledged suicidal ideation, there should be a specific inquiry about the presence or absence of weapons. If they have access to weapons, recommend that the patient or a significant other secure those weapons and document this in the medical record. Assess the degree of suicidality, including suicidal intent and the lethality of a plan. In order to estimate suicide risk, we need to look at demographic factors and psychiatric syndromes. The first step is to establish a multi-axial diagnosis and look at demographic factors, including their age. Between 10 and 24 and after age 70, suicide rates peak. Thoughts of death are more common in older adults, but as people get older, they're less likely to endorse suicide. It is important to note, though, that self-destructive acts by older people are more lethal. This greater lethality is a function of their reduced physical resilience, greater social isolation, and greater determination to die. If they get to that point, they have a greater determination. Suicidal elders also give fewer warnings. A suicide attempt in an older person indicates a much higher suicide risk in the future. Suicide is 4 times more frequent in men than in women. Men who are depressed are more likely to have comorbid alcohol and/or substance abuse problems. And men are also less likely to seek and accept help or treatment. Women have some protective factors, including lower rates of alcohol and substance abuse, less impulsivity. They tend to be more socially embedded and more willing to seek help. Among African American women, rates of suicide are remarkably low. It's theorized that this may be due to religion and social support. Women do, however, have higher rates of depression and respond to unemployment with greater and longer-lasting increases in suicide rates than men. Interesting fact. Women who are pregnant or have young children are less likely to kill themselves. Women with a history of depression and suicide attempts are at greater risk for poor outcomes postpartum. Teenagers, women of lower socioeconomic status, and women hospitalized with postpartum psychiatric disorders may be particularly increased risk postpartum. Rates of suicidal ideation and attempts are also increased in individuals with borderline personality disorder and in those with a history of domestic violence and/or physical or sexual abuse. Suicide in whites and in non-Hispanic Native Americans are approximately twice those observed in Hispanics and non-Hispanic African Americans and Asian Pacific Islanders. For immigrant groups in general, suicide rates tend to mirror the rates in the country of origin, but they converge toward the rate in the host country over time. Racial and ethnic differences in culture, religious beliefs, and societal position may influence the rates and values about suicide. Suicide can be considered a traditionally accepted way of dealing with shame and distress and/or physical illness. Knowledge of and sensitivity to common contributors to suicide in different racial and ethnic groups, as well as cultural differences in beliefs about death and views of suicide, can help the clinician. The suicide rate of single persons is twice that of those who are married. Divorced, separated, or widowed individuals have rates 4 to 5 times higher than married individuals. The presence of another person in the household may also serve as a protective factor by decreasing social isolation, creating a sense of responsibility towards others, and increasing the likelihood of discovery after a suicide attempt. Young married couples may have an increased risk, and the presence of a high conflict or violent marriage can be a precipitant rather than a protective factor for suicide. Gay, lesbian, and bisexual youth have a higher risk of suicide attempts than matched heterosexual comparison groups. The female-to-male ratio for reported suicide attempts in the general population is reversed in lesbian and gay youth, with more males than females attempting suicide. Risk factors, stressors unique to being gay, lesbian, or bisexual include disclosure of sexual orientation to friends and family, and experience of homophobia and harassment, and gender nonconformity. With regard to occupation, dentists and physicians have been consistently found to be at higher risk for suicide. There's also an increase among nurses, social workers, artists, mathematicians, and scientists. Interestingly, farmers may also be at somewhat higher risk, but police officers generally do not appear to differ from the norm. More than 90% of people who die from suicide satisfy the criteria for one or more psychiatric disorders. For younger patients, suicides are more likely to occur early. Patients with mood disorders who died by suicide were more likely to have panic attacks, severe anxiety, diminished concentration, insomnia, alcohol abuse, and a severe loss of pleasure or interest in activities. Suicidal ideation and a history of suicide attempts also augments risk. Comorbid anxiety, alcohol use, and substance use are common in patients with mood disorders. Suicide in patients with schizophrenia is 8.5 times higher. In schizophrenia or schizoaffective disorder, psychotic symptoms are often present during a suicide attempt. Command hallucinations, however, account for a relatively small percentage of suicides. Patients with schizoaffective disorder appear to be at greater risk for suicide than those with schizophrenia. Suicide risk is increased in those who recognize a loss of previous abilities and are pessimistic about treatment. Anxiety disorders are associated with a 6 to 10-fold increase in suicide risk. Eating disorders, particularly anorexia, are a likely risk factor for suicide. Suicide attempts are also common, particularly in individuals with binging and purging behaviors, and in those with comorbid mood disorders, aggression, or impulsivity. The presence of ADHD may increase suicide risk through comorbidity with conduct disorder, substance abuse, and/or depression. Abuse of substances, including alcohol, may be the second most frequent psychiatric precursor to suicide. Alcohol abuse or dependence is present in 25 to 50% of those who died by suicide. Impending impersonal losses and comorbid psychiatric disorders have been specifically linked to suicide in alcoholic individuals. Full-time employment appears to be a protective factor, however, in alcoholics. Factors that increase suicide risk in alcoholics include communication of suicidal intent, prior suicide attempts, continued or heavier drinking, recent unemployment, living alone, poor social support, legal and financial difficulties, serious medical or mental illness, including hepatitis, tuberculosis, or HIV, personality disturbance, multi-substance use. Suicide in alcoholics appears to be a relatively late thing in the disease. So if you have someone who just recently started heavy drinking, they're going to be less inclined to commit suicide necessarily than someone later in the disease, but that's not a perfect indication. Individuals with personality disorders have an estimated 7-time increased risk for suicide. This is especially true for borderline, antisocial personality disorders, avoidant and schizoid personality disorders. Personality disorders exist in approximately 30 to 40% of those who attempt or die by suicide. Specific symptoms or issues that exacerbate someone's suicidal ideation include anxiety, hopelessness, command hallucinations, impulsivity and aggression, alcohol intoxication, past suicide attempts, a history of abuse, treatment history that includes greater treatment intensity. For example, someone who's been involuntarily committed before, or who's been in residential treatment, as opposed to someone who's just been in outpatient treatment. Temporal issues. Risk increases after changes in treatment setting or intensity. When there's a physical illness, or if there's a family history of suicide. Psychosocial factors increasing the risk of suicide are recent loss of employment or lack of employment. Religious beliefs may actually serve as a protective factor. Psychosocial support can serve as a protective factor if it's there and it's healthy, or it can also serve as a hindrance if it helps maintain a person in their addiction. Reasons for living, including children in the home, can mitigate suicidal ideation. And helping the individual focus on psychological strengths as opposed to vulnerabilities can help mitigate suicidal ideation. There are psychodynamic factors that need to be considered as well. Suicide has multiple motivations, including anger turned inward, or a wish of death toward others that is redirected toward the self. Other motivations may include revenge, reunion, or rebirth. Suicide is rooted in a triad of motivations: the wish to die, the wish to kill, and the wish to be killed, and has been associated with poor object relations and the inability to maintain a stable, accurate, and emotionally balanced memory of the people in one's life. A sadistic internal object so tormenting that the only possible outcome is to submit to the tormentor through suicide is another idea that may support suicidal ideation from a psychodynamic perspective. Other important psychodynamic concepts are shame, worthlessness, and impaired self-esteem. Additional considerations when evaluating patients in specific treatment settings. In inpatient settings, patients may be in the midst of an acute suicidal crisis or display the symptoms and disorders that typically lead to psychiatric hospitalization and increased suicide risk. There are not any specific risk factors that are unique to the inpatient setting, and fewer than half of the patients who die by suicide in the hospital were actually admitted with suicidal ideation. Extreme agitation or anxiety, or a rapidly fluctuating course, is common before suicide, and each suicidal crisis must be treated as a new one, with each admission assessed accordingly. In outpatient settings, the initial evaluation should be comprehensive and include a suicide assessment, including strengths, vulnerabilities, and stressors. It's important to be aware that suicidality may wax and wane in the course of treatment, and sudden changes in clinical status, which may include worsening or unexpected improvements in reported symptoms, require that suicidality be reconsidered. Risk may also be increased by the lack of a reliable therapeutic alliance, the patient's unwillingness to engage in treatment or adhere to medication regimes, and inadequate family or social supports. In emergency psychiatric settings, suicide assessment is an integral part. Most patients in emergency psychiatric settings have diagnoses associated with an increased risk of suicide. Over time, be alert for symptoms of physical trauma or toxicity. Now, over time meaning as the person is in the emergency room for 5 hours, watch and be alert to signs that they may have done something which was not initially readily apparent. Patients in emergency settings are often ambivalent and simultaneously seek help, yet withhold information. So it's important to monitor vital signs in order to detect adverse events or signs of substance withdrawal, or again, something that they may have done to harm themselves before coming in. Assessment cannot be completed until patients are sober, and collateral information is often important in emergency settings. One piece of collateral information which can provide some insight is how the patient arrived at the hospital. This provides us information about the patient's insight to their own need for treatment. In long-term care facilities, indirect self-destructive acts are found among both men and women and are a common manifestation of suicide. Physical illness, functional impairment, and pain are associated with increased risk for suicide. Hopelessness and personality styles that impede adaptation to a dependent role also play a role in suicidal ideation. So if you have someone who has historically been very independent and they're suddenly hospitalized in a long-term care facility, they may have an increased risk of suicide. Suicide is one of the leading causes of death in correctional settings. Persons who die by suicide in jails tend to be young, white, single, and drunk. Suicide in correctional facilities generally occurs by hanging, and isolation increases suicidal ideation and ability. Suicidal behaviors often increase immediately on entry into the facility, after legal complications with an inmate's case, after inmates receive bad news about loved ones, or after sexual assault or other trauma within the facility. So once you've done your assessment and determined the patient is suicidal, how do you manage it? Psychiatric management serves as the framework by which the patient and psychiatrist will collaborate. It includes establishing and maintaining a therapeutic alliance, attending to the patient's safety, determining the patient's psychiatric status, level of functioning, and clinical needs on an ongoing basis, and arriving at a plan and setting for treatment. Treatment planning will encompass interventions targeted to suicidality, psychosocial and interpersonal difficulties, and Axis I and Axis II disorders. The first step is building a therapeutic alliance by building trust, establishing mutual respect, developing a therapeutic relationship, paying careful attention to the concerns of patients and their family members, as well as their wishes for treatment. Provide empathy and understanding to help the patient feel emotionally supported, and increase the patient's sense of possible choices other than suicide. And encourage the patient to be independent, yet simultaneously address their safety. Guard against falling into the role of constant savior. Suicidal patients may wish to be taken care of unconditionally, or, alternatively, to assign others the responsibility of keeping them alive. By producing false or unrealistic hopes for treatment and outcomes, the psychiatrist may ultimately disappoint the patient. It's important to remember that taking responsibility for a patient's care is not the same as taking responsibility for the patient's life. Suicidal patients can also activate a clinician's own latent emotions about death and suicide. Countertransference includes feelings of hate and anger toward the suicidal patient, and avoidance of patients who bring up anxiety surrounding suicide. Transference and countertransference can often lead us to overestimate the patient's capabilities, creating unrealistic and overwhelming expectations for the patient. They may become enveloped by the patient's sense of hopelessness and despair, and become discouraged about the progress of treatment and the patient's capacity to improve. When you start feeling yourself develop a sense of hopelessness and despair, it's past time to be consulting with a colleague, to be seeking supervision, because your boundaries are starting to get weak, and you are not going to be able to provide effective treatment if you start to become discouraged. It's important to attend to the patient's safety. Order observation of the patient on a one-to-one basis or by continuous closed-circuit television if necessary. Remove potentially hazardous items from the patient's room and secure the patient's belongings. In the event that restraints are indicated, continuous observation is also strongly recommended. When you're trying to estimate a patient's suicide risk, consideration may be given to the presence of psychiatric illness, specific psychiatric symptoms such as hopelessness, anxiety, agitation, or intense suicidal ideation. Unique circumstances such as psychosocial stressors and the availability of methods, and other relevant clinical factors such as genetics and medical, psychological, or psychodynamic issues. Once factors are identified, determine if they're modifiable. Past history, family history, and demographic characteristics are examples of non-modifiable factors. Financial difficulties or unemployment can also be difficult to modify, at least in the short term. Psychiatric management includes determining a setting for treatment and supervision, attending to patient safety, establishing a cooperative and collaborative physician-patient relationship, encouraging treatment adherence, providing education, And for patients in ongoing treatment, it also includes establishing and maintaining a therapeutic alliance, coordinating treatment, monitoring the patient's progress and response, and conducting ongoing assessments of the patient's safety, status, and level of functioning. The choice of a specific treatment setting depends on the estimation of the patient's current risk to himself or others, medical and psychiatric comorbidity, the strength and availability of a support network for the patient, and the patient's ability to provide adequate self-care, give reliable feedback, and cooperate with treatment. The benefits of intensive interventions must be weighed against their possible negative effects. Be aware of emotions and reactions that may interfere with the patient's care for recurrently suicidal patients. It's often necessary to seek consultation or supervision from a colleague to affirm the appropriateness of treatment plans, to suggest alternative therapeutic approaches, and to help you monitor and deal with countertransference issues. Many of us use a suicide prevention contract, also known as a no-harm contract, but you need to remember that it's not a substitute for a careful clinical assessment. A patient's willingness or reluctance to enter into an oral or written suicide prevention contract shouldn't be viewed as an absolute indicator of suitability for discharge. It's not recommended to use these contracts with patients who are agitated, psychotic, impulsive, or under the influence. And the reliability of the contract is dependent on an established physician-patient relationship. It's not recommended for use in emergency settings or with newly admitted or unknown patients because they have no bond with you. They have no reason to tell you the truth or to hold up a bargain or a contract with you. Unfortunately, suicide happens. Many individuals who die by suicide have seen a clinician within several months of death. Death of a patient by suicide will often result in increased stress and loss of professional self-esteem. When the suicide occurs, seek support and obtain consultation or supervision in order to maintain effectiveness with your other clients. Consult with an attorney or risk manager. And remember that patient confidentiality extends beyond the patient's death, and the usual provisions relating to medical records apply. Conversations with family members may be appropriate, but again, talk to your legal counsel first. Survivors are more vulnerable to physical and psychological disorders after suicide. Patients with suicidal thoughts, plans, or behaviors will benefit most from a combination of medication and therapy. It's important to address the modifiable risk factors and make ongoing assessments during the course of treatment. Target specific Axis 1 and Axis 2 psychiatric disorders. And remember that pharmacological treatment is geared towards acute symptom relief, while psychosocial interventions provide a more long-term picture and help improve interpersonal skills, coping skills, psychosocial functioning, and management of affect. Somatic interventions may include antidepressants. Evidence for a lowering of suicide rates with antidepressant treatment is inconclusive. The effectiveness of antidepressants in treating severe anxiety or depressive disorders is, however, there. Select an antidepressant with a low risk of lethality on acute overdose, such as an SSRI. For patients with prominent insomnia, a sedating antidepressant or adjunctive hypnotic agent can be considered. Antidepressant effects may not be observed for days or weeks, so patients should be monitored closely early in treatment and educated about this probable delay in symptom relief. Benzodiazepines are used to treat symptoms such as severe insomnia, agitation, panic attacks, or anxiety. The long-acting agents are often preferred over short-acting agents, and the benefits of benzos should be weighed against their occasional tendency to produce disinhibition, their potential for interactions with other sedatives, and their potential for abuse. Benzos being discontinued after prolonged use should be reduced gradually, and the patient monitored for increasing symptoms of anxiety, agitation, depression, or suicidality. Other common medications include trazodone, low doses of some second-generation antipsychotics, and some anticonvulsants. With regard to lithium, long-term maintenance treatment is associated with major reductions in the risk of suicide in patients with bipolar and recurrent major depressive disorder. The effectiveness of lithium in decreasing suicidal behavior should be taken into consideration when weighing the benefits and risks of treatment with each medication. The potential toxicity of lithium in overdose should be taken into consideration when deciding on the quantity of lithium to give with each prescription. Clozapine is associated with significant decreases in rates of suicide attempts for individuals with schizophrenia and schizoaffective disorder. It should be given serious consideration for psychotic patients with frequent suicidal ideation, attempts, or both. The benefits of clozapine treatment need to be weighed against the risk of adverse side effects such as agranulocytosis and myocarditis. Other second-generation antipsychotics are preferred over the first-generation antipsychotic agents. Electroconvulsive therapy, ECT, is effective in patients with severe depressive illness with or without psychotic features. It's associated with a rapid and robust antidepressant response and may be recommended as a treatment for severe episodes of major depression that are accompanied by suicidal thoughts or behaviors. Regardless of diagnosis, ECT is especially indicated for patients with catatonic features or for whom a delay in treatment response is considered life-threatening. ECT may also be indicated for suicidal individuals during pregnancy and for those who have already failed to tolerate or respond to trials of medication. Psychosocial interventions are efficacious in the treatment of non-psychotic major depressive disorder and borderline personality disorder. Interpersonal psychotherapy and cognitive behavior therapy have been found to be effective. Cognitive behavior therapy may be used to decrease hopelessness and suicide attempts. Psychodynamic therapy and dialectical behavior therapy are associated with decreased self-injurious behaviors in borderline personality disorder. With patients who attempt suicide, you want to intervene rapidly. Provide follow-up outreach, help them figure out how to better cope with stressors and solve their problems, provide brief psychological treatment, and, if possible, engage them in family, couples, or group therapy. Now let's talk a little bit about determining a treatment setting. Treatment settings include a continuum of possible levels of care. Patients should be treated in the setting that is least restrictive, yet most likely to prove safe and effective. The optimal treatment setting and the patient's ability to benefit from a different level of care should be reevaluated on an ongoing basis. Treatment setting needs to be based upon symptoms, symptom severity, level of functioning, available support system, activities that give the patient a reason to live, whether or not suicidality is related to an interpersonal crisis, the ability to provide adequate self-care, understanding the risks and benefits of various approaches, the ability of the patient to understand what to do in a crisis, the patient's ability and willingness to give reliable feedback to the psychiatrist, the patient's ability to cooperate with treatment planning and implementation, and benefits and costs of different settings. Hospitalization may delay suicide and permit initiation of treatment approaches, but there's no evidence this reduces the incidence of suicide in the long term. Psychiatric hospitalization may also arouse unrealistic expectations in patients, family members, therapists, and medical staff. With patients in outpatient, regular communication among treating professionals is important. Discharge planning should include appropriate continuing treatment to maintain goals and continue monitoring. To increase treatment adherence, discuss the referral with the patient during the interview and arrange a specific appointment time. Individuals with suicidal thoughts, plans, or behaviors may benefit from a variety of treatments. Integrate biopsychosocial therapies. Continually reassess treatment decisions as new information becomes available, the patient's clinical status changes, or both. Work with the patient to implement and modify treatments over time and reduce suicide risk. Know the patient's past responses to stress, vulnerabilities, their resources, their death fantasies, and their capacity for reality testing. Providing optimal treatment involves a multidisciplinary team. Useful strategies for coordination in any treatment setting include clear role definitions, regular communication among team members, and advanced planning for management of crises. Facilitating adherence to treatment plans begins with the initial establishing of the physician-patient relationship and the collaborative development of a plan of care. Side effects or requirements of treatment are common causes of non-adherence. Financial constraints, scheduling or transportation difficulties, perceived differences of opinion with the clinician, and misunderstandings about the recommended plan of treatment are all causes of non-adherence. While symptomatic, patients may be poorly motivated, less able to care for themselves, unduly pessimistic about their chances of recovery, and suffer from memory deficits or psychosis. Additionally, they may have reductions in insight about having an illness or their need for treatment. During maintenance, patients undervalue the benefits of treatment and often focus on its burdens. Specific components of a message to the patient that have been shown to improve treatment adherence include when and how often to take the medication or to show up for treatment, the fact that some medications may take several weeks before the beneficial effects may be noticed, the need to take medication even after they feel better, the need to consult with the doctor before discontinuing medication, what to do if problems or questions arise, and interactions of medications with other over-the-counter medications and or alcohol are often other things you may want to discuss. When dealing with suicidal patients, often there's a family component to it, but everybody needs education. Things to educate the patient and family on include psychiatric disorders, are real illnesses, and that effective treatments are both necessary and available. The role of stressors and other disruptions in precipitating or exacerbating suicidality or symptoms of psychiatric disorders. Ensure that they know that the course of improvement may be uneven, and a family history of suicide may increase risk of suicide, but it doesn't make suicide inevitable. Help them learn how to identify symptoms that may indicate decompensation in general and specifically to the patient. Help them identify methods for involving the police for involuntary evaluation, and teach them how to react to suicidal behaviors in people with borderline personality disorder. A full suicide assessment is not required in each encounter with the patient. In inpatient settings, repeat suicide assessments should occur at critical stages of treatment, such as quarterly, at step down, at the change of a treatment regime, when a treatment plan is modified, etc. Other symptoms that may be associated with increased suicide risk, such as hopelessness, anxiety, insomnia, or command hallucinations. Behaviors that may be associated with an acute increase in suicide risk include giving away possessions, readying legal or financial affairs, or communicating suicidal intentions or goodbye messages. Reassessing the patient's safety and degree of suicidality is important in order to respond to increasing suicidal ideation. It's important to monitor the patient's psychiatric status and response to treatment. Be aware that suicides tend to occur early when individuals are least likely to have insight into the illness and are least likely to adhere to treatment. Be alert to increases in suicide risk as depressive symptoms begin to lift, but before they're fully resolved. Be flexible as different features and symptoms of the patient's illness may emerge or subside. Obtain consultation. Monitor and address countertransference issues through consultation with a colleague. Use consultation in order to affirm the appropriateness of the treatment plan or to get suggestions for other possible approaches. Use consultation for the management of a program of recovery with patients with concurrent addictive issues. But be careful in referring long-term patients for consultation. Some patients may perceive such a referral as the first step to termination of therapy. Special issues. When patients are in suicidal crisis, it's critical to speak with the patient directly. Under some circumstances, the psychiatrist may need to refer a suicidal patient to an emergency department for evaluation or hospitalization. Self-injurious behaviors in patients with chronic suicidality may or may not be associated with suicidal intent. Self-injurious behaviors are sometimes characterized as gestures aimed at achieving secondary gains. Without having any desire for death, individuals may intentionally injure themselves to express anger, relieve anxiety or tension, generate a feeling of normality or self-control, terminate a state of depersonalization, or to distract or punish themselves. Conceptualizing such behavior as gestures may lead to suicide attempts being downplayed when associated with minimal self-harm. In assessing chronic self-injurious behaviors, determine whether suicidal intent is present. An absence of intent or a minimal degree of self-injury should not lead the psychiatrist to overlook other evidence of increased suicide risk. Each act needs to be assessed in the context of the current situation. Borderline and antisocial personality disorders predominate among patients who exhibit chronic self-injurious behaviors without associated suicidal intent. They have higher rates of comorbid panic disorder and PTSD, and there's evidence that the presence of comorbid personality disorders or substance use disorders not only increases suicide risk, but also decreases treatment response. Documentation and risk management. When do you document? After an initial evaluation, for patients in ongoing treatment, when suicidal ideation or behaviors emerge, when there is significant worsening or dramatic and unanticipated improvement in the patient's condition. For inpatients, reevaluation also typically occurs with changes in the level of precautions or observations, when passes are issued, and during evaluation for discharge. Communications with other caregivers and with the family or significant others should also be documented. And specific instructions about firearms or other weapons should be noted in the record. The most frequent lawsuits, settlements, and verdicts against psychiatrists are for patient suicides. The failure to document suicide risk assessment and intervention may give the court reason to conclude that they were not done. For patients who are hospitalized, it's also important to document the aspects of the risk assessment that justify inpatient treatment, particularly when it occurs on an involuntary basis. Your documentation needs to include reference to the reason for the assessment and the context for the evaluation. It needs to review the factors that contribute to increased shorter-term or longer-term suicide risk, the reasoning process that went into the assessment, clinical conclusions, changes in the treatment plan and the rationale for such actions, and interventions or actions that were considered but rejected should be recorded as well. outpatient treatment, documentation should be completed at admission, changes in the level of precautions or observations, transitions between treatment units, the issuance of passes, if there are marked changes in the clinical condition of the patient, and an evaluation for discharge. For outpatient treatment, there should be documentation of the initial interview, at the emergence or reemergence of suicidal ideation, plans, or behavior, and when there are other significant changes in the patient's condition. Now, this is documentation in addition to your normal progress notes. The patient's willingness to enter into a suicide prevention contract should not be viewed as an absolute indicator of suitability for discharge. It is an overvalued clinical risk management technique. It's not a legal document and cannot be used as exculpatory evidence in the event of litigation. It cannot and should not take the place of a thorough suicide risk assessment. Although suicide prevention contracts are commonly used, no studies have shown their effectiveness in reducing suicide. Undue reliance on suicide prevention contracts falsely lowers clinical vigilance without altering the patient's suicidal state. Patients who reject them are communicating that they see the therapeutic alliance as suboptimal, or that they feel unable to adhere to such a contract. These contracts are only as reliable as the strength of the therapeutic relationship, so don't use them in emergency settings or with newly admitted or unknown patients. They are also ill-advised with agitated, psychotic, or impulsive patients, or when the patient is under the influence of an intoxicating substance. If the patient is, or is likely to become dangerous to himself or herself, or to others, and the patient will not consent to interventions that aim to reduce those risks, then the psychiatrist is justified in attenuating confidentiality to the extent needed to address the safety of the patient and others. In an emergency situation, necessary information about the patient can be communicated with police and with emergency personnel, including medical staff and emergency medical technicians. Suicide can lead to symptoms of PTSD, shock, anger, grief, guilt, isolation, shame, diminished self-esteem, and concern about reactions of colleagues. Half of the psychiatrists who had lost a patient to suicide experienced stress levels comparable with those of persons recovering from a parent's death. Support for the psychiatrist and a review of events leading to the suicide are warranted. Seek consultation or supervision to enable continued effectiveness in working with other patients. And conversations with family members may be appropriate, but seek legal consultation first. It's important to remember that survivors currently experience intense emotional pain, and a number of lawsuits are filed because of the clinician's refusal to express feelings of condolence, sadness, sympathy, or regret. Many states have statutes that prohibit statements, writings, or benevolent human expressions of sympathy, such as condolences and regrets, from being admissible as evidence or admission of liability in a civil action. However, statutes often distinguish between the part of the statement that's an expression of sympathy and the part of the statement that expresses fault. So again, seek legal consultation. Interventions for mental health survivors. The survivors of suicide are more vulnerable to physical and psychological disorders and are at increased risk of suicide. Symptoms of depression, PTSD, guilt, and shame, as well as somatic complaints, are prevalent and are more severe among parents of deceased children. The majority of bereaved adults within 6 months after a suicide acknowledge a need for intervention, but only 25% seek psychiatric treatment. Within 6 months after the suicide of a friend or sibling, symptoms of major depressive and post-traumatic stress disorder are prevalent among bereaved youth. Within 6 years of the suicide of a friend, adolescents with syndromal levels of traumatic grief were 5 times more likely to report suicidal ideation. For all family members and close relatives of individuals who die by suicide, referral to a survivor support group can be helpful. Crisis intervention is client-centered and comprehensive. It uses patients' strengths and resources. Empathy and genuineness are key factors. Treatment modalities and settings are based on the client's level of functioning, dangerousness to self, and availability of supports and resources. Documentation is essential throughout the process, not just at assessment. Pharmacological interventions are used to provide acute symptom relief and enable the patient to focus on psychosocial interventions. And it is very important to remember that all clients have the ability to help themselves.